And so if you come up with questions, if you think of anything you'd like to ask, please stick it in the Q&A box, and we will get to those questions over the course of our hour. Also, just real quick, we are in the middle of accepting for our Mississippi chapter nominations for 2 positions. We have a central district board of director opening and an at-large board of director opening, along with the secretary treasurer. So if anyone has an interest in either of those 3 positions, please email Deanna. We would love to have participation from throughout the state in our board, because it just really helps us to serve the whole state of Mississippi. So with that, I'm going to go ahead and turn it over to Dr. Hobbs. And one last thing, if you haven't joined and you're interested in joining, there was a link. AAPMS is our website, and you can join our Mississippi chapter. You can join the national chapter or both. And so we would love to have you guys as members. All right, I'm going to turn it over to you, Dr. Hobbs.
Okay, so I'm just going to give a brief introduction and then let Dr. Byers have the stage. Basically, I think all of us who have been in the state over the past few months feel like this cat on this tree, which is what my husband sent to me when I was on service week before last. Basically, this is an update to address several of the questions that Dr. Henderson had brought to the attention of both Dr. Byers and myself to walk through in this talk to help guide providers during this very difficult time. So the first 20 minutes will be the Department of Health's stage to talk about epidemiology and review isolation quarantine guidelines and some Q&A. And then I'll go over some data for advocacy for masking, COVID treatment protocols, a little bit on long COVID and a little bit on sports. And then we'll have hopefully a little bit of time for Q&A at the end. So with that, I will actually drive the slide presentation, Dr. Byers, if that's okay with you. So just tell me next slide and we can start with that. Can everybody see my screen okay?
Yes, ma'am, we sure can.
All right, thanks.
Thank you, Dr. Hobbs and Dr. Henderson and Deanna. Thank y'all for the opportunity to speak with y'all again. So this first slide is a slide of our pediatric deaths that are COVID associated. We sadly reported out an additional death this week in a child less than a year of age. This was a pretty rapid acute onset. There's no indication that it was associated with multi-system inflammatory syndrome, but we have had a number of deaths in pediatric cases that have been associated with MIS-C. And I think as we move forward with the astounding number of cases that we've had over the last several weeks, that we will in fact see additional cases of MIS-C, and the risk that we'll see additional pediatric deaths is very high, I think, at this time. We can go to the next slide. If you look at our overall confirmed pediatric hospitalizations, you can see that we had a rapid rise. Those 2 previous peaks coincide with our summer surge that we had last July 2020. And then again with our winter surge, you can see that we far exceeded that. We have had some decreases in our overall number of pediatric hospitalizations, but they're still very high, even though we have seen that we're seeing some downward trend. If you look at the 7-day moving average, it's still pretty elevated and certainly way above what we were seeing with previous surges. And you know, Delta has been had a particular impact on pediatric cases, and I think there's national data that has supported the hospitalizations for kids, especially in states that have had lower vaccination rates. And you know, although we've had a bump in our vaccinations recently, we and have seen you know, higher vaccinations among those eligible kids as well, about a little over 24% in our children aged 12 to 15, and about 28% of our kids 16 to 17 years of age have been fully vaccinated. Overall as a state, we're at about 40% fully vaccinated, but that still lags way behind the rest of the US. We can go to the next slide. And this is just another slide depicting our confirmed hospitalizations for pediatric cases over time. And again, we've seen a little bit of a downward trend, which is so encouraging, but we still are very, very high. And I think we still have very high levels of community transmission of COVID. And as long as we do, we're going to continue to see high levels of pediatric hospitalizations. We can go to the next slide. In pregnant women, it's been particularly hard these last several weeks. And this number is going to grow. We still have some other COVID-associated deaths in pregnant women that we're investigating and that we're getting information on. And for you folks that have any relationship with pregnant women, please encourage them to get vaccinated if they're not. These COVID-associated deaths in pregnant women, these are all unvaccinated pregnant women to date. So we've had a very high number of deaths since August 1, at least 5, but that number is going to probably grow to 7 or more once we continue to look at the data. We are going to be, now, pregnancy status is already reportable for COVID-associated death, but we're going to be sending out information today that is going to remind providers that it is explicitly reportable, that if you know the pregnancy status on a COVID-associated death, please report that to us so that we can have that data, and we'll be asking for additional data elements on that. So please encourage your pregnant women that you have any influence over to please get vaccinated. We can go to the next slide. We still see a very high proportion of our cases in pediatric patients, 24% in September so far. And that number, that's just with a little bit of data so far in September. So that, take that number with a grain of salt, that it looks like it's dropping down a little bit. But in August, 27% of our cases were in kids 0 to 17 years of age. And you can see how rapidly that grew from January of 2021. And at the same time, you can see the level of cases that have dropped in the older population. Certainly part of that may be due to vaccination, and we hope that that's the case, because in our population over the age of 65, we have well over 70% of those folks fully vaccinated. But the kids, again, have been particularly hit hard with this Delta surge that we've seen. We'll have to continue to watch that data. Hopefully we will see some downward trends as our overall case numbers come down. But again, we've seen lots of cases in kids, and this is just another illustration of how the overwhelming proportion of those cases have been in those younger age groups. We can go to the next slide. Again, this is our most current epi curve. Y'all have seen this before. We had a staggering rise in our case numbers with these Delta surge. It does look like we're starting to trend down. Don't misinterpret that gray area though. That marked out area is probably going to be backfilled as we get more cases reported to us. So there's always a bit of a lag in reporting. I don't think it's going to be the sharp drop off that seems to be illustrated in the current epi curve. But we are having some downward trends and some leveling off. Today, we reported out over 1,800 additional cases. That's certainly better than we were a couple of weeks ago on the daily reports, but we did have an additional 35 deaths. We can go to the next slide. And when you look at the deaths, it also appears that we're having some leveling off or trending down. But remember, we're going to be dealing with this very large surge of cases for a while now. And it takes, a week or two before somebody becomes ill enough where they may even be hospitalized or have a death. And so those numbers are going to backfill as well. We anticipate that we're going to get continued numbers of deaths reported that are going to be high for the next little while as we deal with this very large surge in cases that we've had. And again, because of the overwhelming number of cases that we've had in kids, that's going to translate to more hospitalizations and more severe illness in kids, and potentially more MISI down the road. We can go to the next slide. If you look at the staggering number of cases that we actually had in August, and this number is not final yet because we're still getting reports of cases that had onsets in August. But when you look at that 93,000 cases in August alone, that really overshadows any previous peak that we had. And that was just a 1 month total, almost 100,000 additional cases in 1 month. And, again, that's going to translate to severe illness in several folks. And unfortunately, we'll continue to see deaths. And we may approach the same level in September, but we hope it's not going to be quite that high. But we still got a lot of transmission out there, even though we're seeing some downward trends. We can go to the next slide. And if you look at the number of deaths that we had, over 1,000 deaths in August alone. Again, that number will grow as we continue to get deaths reported to us that occurred in August, because again, there's a delay in reporting. And we're just now in the second week of September. And so we anticipate that that number will grow as well. Did not reach the level of our winter surge, and that's encouraging, but we may well have 1,000 deaths in September as well. So we'll keep a close watch on that. Next slide. We've had some encouraging data with our hospitalizations, and that's been good. We looked at the pediatric hospitalizations a moment ago, and certainly they were trending down. Overall, our hospitalizations, our vent use, and our ICU care has dropped as well. But these are slow declines, and they are still at very, very high levels. Still a lot of pressure on the hospitals. The hospitals, with us seeing decreases in the number of ICU patients that are COVID related that have had that have been in the hospital, we've seen increases in ICU capacity or in people in the ICU who are non-COVID. So the amount of beds that are available that are ICU are still dangerously low in the state, even though we've had some drops in our COVID associated ICU care. So next slide. This is the school reported data. And you can see that for those numbers of students, teachers, and staff that have had to be quarantined, and again, just to set the stage on this is self-reported data from the schools. We ask that all the schools report to us on a weekly basis the number of students and teachers that are on quarantine, the number of students and teachers that have been reported to them as cases, and the number of outbreaks that they have as well. And so the number of schools that report to us on a weekly basis is a little bit variable. It's usually about 800 plus. We did have less schools reporting to us post-hurricane. That was the week of August 23rd through 27th. So we didn't have as many schools reporting to us, but we still had 23,000 students on quarantine. Now we had over 800 schools report to us in the most current week, and that's the week of August 30th. And we did see a downtrend in that. So that's encouraging that we are starting to see less impact in the school settings. We can go to the next slide. And we see the same with the number of cases in teachers and the number of cases in students and the number of outbreaks. Again, that was over 800 schools that reported to us. The good news in this as well, and I think this is one of the encouraging pieces, is that over 80% of those schools that reported to us in that week of August 30th indicated that they were requiring masks indoors in the K-12 setting for all students, teachers, and staff and visitors, regardless of vaccination status. And I think that that's been a big win for us. And y'all have been a big part of that, because y'all have been talking to the school boards and working with the school boards in your area. And we certainly appreciate that. In addition, we've worked with the schools through our Adopt a School program to get kids and teachers vaccinated on site. We've had over 96 individual schools and another 26 school districts that have participated in that Adopt a School program, where providers like yourselves adopt those schools, go directly on site, and make that vaccine available for them, for all those eligible teachers and staff and students. And so that's been a big piece of this. I encourage y'all to look at our website around Adopt a School and continue to work in those efforts. And if you have some questions, y'all can give us a shout about that. Next slide. If we look, and we talked about this a moment ago, we did see an increased demand in our vaccinations with the beginning of the Delta surge as we got the word out. And at one point we had over 80,000 vaccines administered in a given week. You can see in that bottom graph that we've dropped off a little bit over these last few weeks. And we're having less people initiate vaccine. We're seeing more of those vaccines that were given in the last couple of weeks being those people who are coming back for their second dose. And so we've seen some drop off in people initiating vaccine, but we've had some continued steady growth. And you see that we've had some continued growth in our childhood vaccinations for COVID as well. And we want to continue that steam rolling up, but it's an uphill, slow climb, I'm going to tell you. Next slide. And just again, a reminder of where we're seeing most of our cases, hospitalizations, and deaths. The overwhelming majority is in those unvaccinated individuals. Now, granted, this includes a very large proportion of people, apologies for my crazy dog, a very large proportion of people who are not eligible for vaccine yet, right? We have all of those kids under 12 who are not eligible, and they're included in these graphs. But you can see that still the overwhelming majority is in unvaccinated folks. We can go to the next slide. This is just a reminder of where we are with community transmission. I get a lot of questions from schools about when can we stop mask mandates. We're trying to look at all of these different metrics for when we can say that masks are no longer required in the school setting. So CDC recommends that masks be used in the K-12 indoor settings, period, right now. And that's what we need to go with. Now, when we look at one of the metrics that CDC really wants to pin the mask indoor mask use on, it's the level of community transmission. This is on CDC's website. I encourage you to look at it. You can see that the entire state of Mississippi essentially is at high or substantial transmission right now. And although we anticipate that over the next coming weeks, that's going to come down some, but we are still in very high levels of community transmission across the state and really across the United States. So I encourage schools not to try to define these very, very specific metrics that they want to use around their county for determining when to stop using masks. The recommendation right now is mask, period. We can go to the next slide. And I know that we had some questions about this, about isolation, about quarantine, about what it is. And so just remember, isolation is if you're a case, and if you're test positive, you need to be isolated for 10 days from the date of onset or the date of your positive test if you had no symptoms. That's the anticipated infectious period. So really what we recommend to schools and what we recommend for kids and for teachers is if you're a case, you need to be isolated for a full 10 days. I know that we've had some, and I've gotten some questions from schools where they get a local doctor who has told them, well, the child's not symptomatic anymore, so they can go back before the 10 days. That's not true. Those kids still may be infectious for that full 10-day period. Delta has a very high viral load, way more than what we've seen with previous versions of COVID. And so we really need to keep those kids isolated and excluded from the school setting for that full 10 days. For the exposure, remember that exposure is 15 minutes or more cumulative time frame, cumulative contact over a 24-hour period at less than 6 feet. We do have an exclusion in there, and that exclusion is if they are in the classroom setting, if they are, and CDC allows that if you're in a classroom setting, if you're in a static environment where you're sitting at your desk and the desks are separated out by at least 3 feet, and everybody is wearing a mask, that if there's a case in that classroom, that those other individuals would not have to quarantine. They would not be considered exposed. But everybody's got to be wearing a mask and wearing it consistently, and there has to be a minimum of at least 3 feet between. And this exception only applies to the students. It does not apply to the teachers right now or the adults in that classroom setting. We can go to the next slide. And the last thing that I want to talk about, and I think this is pretty much the end of my slides, is that fully vaccinated kids in the class, fully vaccinated teachers do not have to quarantine if they are contacts or exposed. We do recommend that they get tested. At 3 to 5 days is going to be the best time frame for them. But if they're fully vaccinated, they don't have to quarantine after exposure. And additionally, those people who have been cases, they don't have to quarantine if that exposure occurs within that 3-month time frame of when they were infected. But in other settings, the standard definition applies for who is exposed. And I think we talked about that. And the last thing that we get a lot of questions about, and this has been a standard that we've had in our guidance from the very beginning, that if a workplace or a school deems that teacher as essential personnel, they can continue to work in that quarantine period as long as they are asymptomatic, they wear a mask at all times while indoors, they self-monitor, and they really self-quarantine at all other times. So really all we want them to do is go back and forth to school. They've got to be at home the rest of the time. And I think that was all of my slides, Charlotte. And we talked about that.
We already talked about this. So and you talked about this too. I just put a couple questions in here that Dr. Henderson had sent that I was hoping we could just
Yes, ma'am.
address really quickly, or however much time you need.
So rapid antigen test. Rapid antigen test, we do have a school-based testing initiative program where we have several schools and school districts that have signed up, and I think it's close to 100 now, have signed up to participate in this program. And we do provide them with rapid antigen tests to use for screening of asymptomatic, unvaccinated students and teachers in their school setting. And really the intent of that is to try to identify those cases early. So if a rapid test is positive, we recommend that they immediately get excluded from the school setting and considered a case if they have a rapid antigen positive. Now, if they have a PCR that is collected within 48 hours of that rapid test and they are asymptomatic and that PCR is negative, then we don't count them as a case and they can go back to the school setting. So rapid antigen positive, but asymptomatic with a negative PCR that's collected within 48 hours. If that PCR is negative, then we can allow them to go back and we would not consider them infected. I hope that answers the question. Anita, please direct me if it didn't. As far as home tests are a tough one, guys, because one of the things that we lose with a home test is, making sure that the test was collected appropriately, making sure that it was interpreted appropriately, and making sure, and I'm not saying that people are devious, but making sure that it was actually collected on that person or even collected at all. And so what we recommend to schools is if somebody reports to you that they have a home test positive on their student or a home test positive on that teacher, that you accept that as a positive and exclude that person from the school setting and do contact tracing to identify contacts around that reported home test positive. In general, though, what we recommend with home tests is that if somebody does a home test that's positive, we encourage them to see their provider. We encourage that provider to report it to us through our normal reporting mechanisms if that provider has evaluated that patient and feels like that truly is a positive test. And we'll accept that if the provider reports it to us. As far as home tests to use to test out of quarantine, and we have test out of quarantine options, and I'm afraid I didn't cover that very well. But for those people who are on quarantine, our recommended quarantine period is 14 days. Excuse me, but they can come back sooner at 10 days if they remain asymptomatic that entire time frame. They can come back after 10 days, or they can come back after 7 days if they remain asymptomatic and they have a negative test that's done at day 5, 6, or 7. That negative test can be a rapid antigen, and we have instructed the schools that they can use that rapid antigen that we provide them to do that testing. It's not perfect, but these are asymptomatic individuals who are several days into the course of their exposure. And I tell you, for these people who are positive with Delta, the viral load is so high that we have seen that those rapid antigen tests are much more sensitive than what we were seeing early on. But what we don't accept is a home test to get out of quarantine. So we encourage it to be a test that's collected by somebody that and can interpret it on those kids. And so we don't do the home test for testing out of quarantine. And the daycare's asking for negative test after 10 days. That's just not recommended. And we've instructed the daycares not to do that. We've provided some guidance to the daycares, very similar to the guidance that we've provided for the K-12 settings. And we've continued to discourage that practice. It's not necessary. If you're out 10 days from your onset of illness or your date of test, then we would not consider you infected.
There's one question real quick in the chat box.
Yes,
Are
ma'am.
you allowing the rapid antigen on day 5 just for kids, or is that something that can be used on all age groups for asymptomatic people?
That can be used on all age groups.
All age groups. Great.
Accept that.
Great. Thank you for all those answers.
Yes, ma'am.
So before I launch, Dr. Byers and Dr. Henderson, are there any other questions that we missed or that you'd like to address before I go into the next section of the talk?
Go for it.
All right. Okay. So I'm going to use my career that I've told I should have pursued, which is being an auctioneer, in the next section of the talk to just talk through some of the topics that Dr. Henderson had mentioned that she thought would be quite important to address. So Dr. Byers, please just interrupt me whenever you need to, or perhaps the dog will start barking again and just get tired of me. So,
And I'm sorry it took so long. Yeah.
No, I was happy. So, so I think one of the big questions that Dr. Henderson did pose, which is really quite important, is with regard to what we as pediatricians or pediatric providers can do in order to advocate for schools to do the right things. And I'll leave some time to discuss that in a bit more detail, but I would humbly submit to the group that if we have our epidemiology and vaccine efficacy and masking data straight in our heads, that is a huge and powerful weapon in our arsenal to use to educate the heads of schools and providers to give information to parents and to schools to really underscore the recommendations of CDC and the Mississippi State Department of Health with regard to universal masking and urging all those who are eligible for vaccine to get it. Unfortunately, of course, this was actually an article that Dr. Dobbs had sent around in Mississippi Today, pediatrician parents saying that Mississippi's largest school districts are ignoring their COVID advice. So again, if we have our facts as straight as possible, and I am continuously shocked at some of the questions that seem to be continuously posed, particularly in the media sometimes with regard to even evidence behind masking. If we have our data straight, and I think those MMWR cartoons, which I'll show a few in a second, are really helpful, then hopefully we can provide the schools with the information they need to protect our children. So I know Dr. Byers had lots of beautiful slides in epidemiology. This actually is a bit of a cheating slide because it's New York Times collated data slide. But basically what this shows is that, as Dr. Byers pointed out, COVID hospital admissions for children in general in states with low immunization rates are climbing. And of course, we all know in the state of Mississippi, as Dr. Byers pointed out, that Delta variant in particular in children has had such a huge impact, specifically because we think again, this is a hypertransmissible variant on a background of really suboptimal vaccination across the population for those who are eligible. So basically, again, as Dr. Byers also pointed out, we have this tremendous peak in cases here that he already highlighted. And of course, the ramifications of that continue to remain to be seen and will echo as waves over the next few weeks. I think this graphic is actually quite striking. And again, just to highlight, again, I know Dr. Byers pointed a lot of this out, but this red line here is of course our pediatric age group. And you see this tremendous increase. And again, this is data that is current as of September the 2nd from the Mississippi Department of Health website that I actually just downloaded today. But as Dr. Byers said, there's more information to come. So this actually may look even worse as the weeks go on. And I think many of you probably have seen this graphic, which is really actually a download from the AAP. The AAP again has a report every month for pediatric COVID cases for states that actually contribute data to AAP and the Children's Hospital Association. This actually, I did check for an update today, but this is still as of 8/12. But you can see, of course, we do see this progression of increase in child cases, but this already is actually outdated. And of course, hopefully the site will have some updates soon. But as we've seen from our own state data, we have tremendous spikes in illness in children. So this is what I was talking about the MMWR cartoons and to know your epidemiology. We know that the data shows that there's been this tremendous spike in pediatric COVID hospitalizations in children and adolescents since the rise of the Delta variant. And this, the supposition or hypothesis here is not that Delta necessarily is more virulent in children, although that of course remains to be seen with further research, but really a percentage of a larger number is a larger number overall. And so just numerically speaking, we know that we're seeing these increases because of the hypertransmissibility of this variant and the suboptimal vaccination rates in our own state, which are, again, obviously quite unfortunate, but are things that we continue to try to address. I know we all do. In those ages 0 to 4, there's been a tenfold increase in pediatric hospitalization since the rise of Delta variant. And this is actually, this is the little cartoon that MMWR puts out that I think, again, these are quite helpful when communicating information, but this is the actual graph that shows the this, again, increase in the number of hospitalizations, with the darkest blue being those 0 to 4 years, the sort of medium blue being 5 to 11 and 12 to 17. And this is, again, only through August 21st. And I think we all know that, again, this data is lagging, but it's still actually pretty striking. So just to talk a little bit about treatment in children, we know that outpatient wise, there really is no evidence behind the use of steroids for children who are diagnosed with SARS-CoV-2 outpatient, azithromycin or ivermectin. And here is, of course, Dr. Dobbs giving evidence and asking, pleading for people to not use things like ivermectin, really overall period, but certainly I've actually heard that some people are actually using this as a prophylactic in lieu of the vaccine, which is also quite striking. And so again, there is no evidence to support this. We have a really great actually a few vaccines now. So please advocate for those who are eligible to get the vaccine. Outpatient acute SARS-CoV-2 care in children, again, is limited to supportive care. And also, depending on risk factors and age and weight, the monoclonal antibodies that I'll talk about in a second. Once a child gets hospitalized with acute SARS-CoV-2, most of our algorithms are really based on the adult literature, and the NIH guidelines for children are available and do review the most recent data, but really the triad of treatment remains anticoagulation, which does vary depending on the situation. And so consultation with your hematology oncology doctor is always recommended. And then of course, remdesivir, actually, if it's going to be used, should be used quite early. Of course, we want to make sure that children, if they are receiving remdesivir under the approved indications, that it is used early. And also, of course, you check renal function and liver function tests when evaluating whether or not to use remdesivir. But the earlier you use remdesivir, the better. And in fact, remdesivir is actually one can use remdesivir down to age of 3.5 kilograms at this point. And we actually have used remdesivir in a few cases in those less than 3.5 kilograms through an off-label use after discussing with our IRBs and also with the Gilead directly. If you literally Google remdesivir and Gilead, there's a 1-800 number that comes up, and there's a available person to answer questions, but it is possible to use this actually off-label in infants. Again, there is limited data. There are trials all over the world right now going on with remdesivir in infants. So there is limited data, but there hopefully will be more soon. But if you basically have nothing else that you can use, and you've tried your steroids, it is better to start remdesivir earlier than later, because infants actually are within the group that actually can suffer quite severe SARS-CoV-2. So use it with caution. It is an off-label indication for those less than 3.5, or sorry, it is off-label for those less than 3.5 kilograms, but it is something to think about. And for multisystem inflammatory syndrome in children, MRIC or MIS-C, basically we have the American College of Rheumatology guidelines. This is a diagnosis of exclusion, and the mainstays of therapy I'll talk about in a second, but essentially boil down to treatment of a hyperinflammatory syndrome based on a lot of Kawasaki's algorithms. Again, MIC or MIS-C is completely distinct from Kawasaki's disease. You don't have to look like you have Kawasaki's to have MIS-C. But basically the mainstays of therapy parallel treatments for these other hyperinflammatory syndromes like Kawasaki's. Again, just because there's limited time, I am going to talk a little bit, a tiny bit of detail about some of these treatments, but I want to highlight for the providers on the call that the NIH does, of course, have COVID treatment guidelines that are pediatric specific. The American College of Rheumatology version 2 guidelines for MIS-C treatment are available online. And actually the board is meeting, I met this week to revise those guidelines. So new versions should be coming out soon. And I'd like to point you to the PEDS ID Society, which has a listing of COVID resources available for providers, including, Infectious Disease Society of America, CDC guidelines, and so on and so forth. So just a quick word about the monoclonal antibody. This is actually, I think, quite important to talk about in this talk. That, of course, we remember there was a health alert network alert that came out on August 15th from the Department of Health that because of the surge in the state with cases and those unvaccinated and vaccinated who are at risk for progression to severe illness who have tested positive, and there's even a prophylaxis indication, monoclonal antibody or the REGEN-COV antibodies basically can be used under emergency use authorization down to age 12 and 40 kilograms. There are specific indications for the use in patients who are at higher risk for progression to disease. These are, of course, available through the HAN, and I won't go into them in detail. They are available through the Mississippi Department of Health website, and infusion centers or centers of excellence that administer the antibody are actually set up to administer this. But I would like to just mention, because this question was posed multiple times over the past few weeks, what do we do about those who are less than 12 who are high risk? who are exposed or infected. For example, single ventricle patients, as one of the cardiologists at Mississippi, University of Mississippi Medical Center was asking me about, our sickle cell patients, so on and so forth. There is a consideration, and it does require a lot of paperwork, but there is a consideration for compassionate use. You are evaluating does not fall under the EUA, and there is a process in place that needs to occur if this does occur. And again, I would mention that the Peds ID Society just came out with guidelines, actually, well, not just a couple months ago, and they're actually being updated now, that show that there's really not, substantial amount of data to support the use of the monoclonals right now, but they are updating those guidelines, and that information should be coming out really quite soon. So really, if there is a high risk case and the child does not fulfill criteria by the EUA, there is actually an option to call Regeneron and actually discuss with them the potential use of this under compassionate use. And they actually will assist with dosing. Basically, the earlier you do this, the better. And this is also just emergency use. So you do have to work with your institutional review boards if you're going to undertake compassionate use. I'd just like to reiterate that again. You have to speak with your IRB because this is not under an EUA. This is compassionate use. So this is to be used very selectively, but the protocol is basically you contact Regeneron and go through your dosing and indications, make sure you're talking to your IRB, and actually, that's the basic sort of flow of things. I'm going to sort of speed up and talk really briefly. I'd like to just emphasize, because somebody asked me this question again yesterday, MIS-C or MIS-C is a post-COVID hyperinflammatory syndrome. You do not get MIS-C with acute COVID infection. Usually MIS-C occurs about 4 to 6 weeks after an acute COVID illness. There are some references that talk about within 2 weeks, but what we're seeing at the hospital now is a lot of kids are coming in with RSV and COVID at the same time, and they have this tremendous hyperinflammatory response. MIS-C is a clinically distinct syndrome in the sense that it is a post-COVID hyperinflammatory syndrome. So sometimes it's difficult to distinguish and tell, but you always have your friendly rheumatologists and Peds ID specialists that you can call with questions if you're suspecting MIS-C. In a nutshell, MIS-C has a few different definitions by the Rural Pediatric Society definition, CDC and WHO. For us, really, we of course abide by the CDC's definition, and CDC has a lot of literature in terms of what to do if you think your child is sick with MIS-C. Symptoms are very, very non-specific, as you can see here. Children tend to present with abdominal pain. They can have bloodshot eyes that look like Kawasaki's, but they don't have to. Chest tightness or pain, diarrhea, feeling very tired, headache, low blood pressure, neck pain, rash, and vomiting are all symptoms that are not limited to, but are frequently seen with MIS-C or MIS-C. And you do have to have the presence of fever, either historically or recorded for at least 24 hours. With evidence of multisystem involvement. And I'd like to highlight here, no alternative plausible diagnosis. So MIS-C is a diagnosis of exclusion. If you have a child who comes in who's hypotensive, you're basically treating for septic shock or toxic shock, depending on the clinical syndrome and symptoms, until you know otherwise. And it's very important that we all remember that, because I think that there's a lot of knowledge of MIS-C now, which is fantastic, but we don't want to forget all the other stuff that does happen. Lines that actually go through very algorithmically. This is really helpful, I think, for providers to go through, what do I do if I think a child has MIS-C? And they go through these criteria. Does a child have all of these following characteristics? Unremitting fever, an epi linked to SARS-CoV-2, which basically everybody in the country right now has. And I will also note that studies have shown that kids that have MIS-C don't actually necessarily report an antecedent COVID infection. In fact, frequently they're very healthy kids and they're asymptomatic. I can't go through this algorithm in great detail, but suffice it to say, this algorithm isn't available on the American College of Rheumatology version 2 practice guidelines on PubMed. And this will be quite important because this actually gives you a tiered evaluation for when to suspect MIS-C, and of course seek emergency care if anyone is experiencing trouble breathing, persistent pain or pressure in the chest, new confusion or inability to stay awake, or pale gray or blue colored skin. I almost said green. I guess if you're green, that's bad too. So just, Dr. Byers reviewed a lot of this already, but also mentioned the concerns over MIS-C. This is updated as of 8/22, but basically we're starting to see a slow uptick in MIS-C cases. It's not really reflected on this particular graphic, but we did see this big increase in the wintertime nationwide. But just to remind everybody, this is probably still remains to be seen. This is Mississippi State Department of Health data. And as Dr. Byers and I were talking about on the call before this, the Department of Health is receiving new cases to adjudicate. So we may actually see a further increase in this based on that. And as the weeks go on, given the epidemiology of what we know about MIS-C already, we expect this to actually increase. So please be on alert for this condition. But again, please remember, not everything is MIS-C. This is actually a flow chart that our emergency room had developed that basically gives you a brief synopsis of what to do if you're thinking about MIS-C to obtain your basic labs, your physical exam, and depending on whether or not your physical exam is concerning and your vital signs, of course, being a big part of that, you have a low threshold to admit a child if you're concerned about MIS-C, because these kids will crash very, very fast and they need to be treated early. So this condition is not common. It will become more common probably as the weeks go on. But if you don't recognize it or think about it, these kids will get sick and they will go downhill very, very, very quickly. So please don't forget this. And we can actually send out probably, I think, recordings and slide decks so everybody look at this later. This is just a basic algorithm of how we actually treat a hospitalized child with MIS-C. And again, the algorithm involves the use of treatments that reduce this tremendous hyperinflammatory response that these kids get. Other post-COVID conditions, long COVID, we haven't seen a whole lot of long COVID. I do think that it's really important to stress to providers that long COVID is really a diagnosis of exclusion. A lot of children, not to say this is not a real clinical entity, first and foremost, but it is a diagnosis of exclusion. A lot of children, of course, are suffering non-infectious related consequences of the pandemic. They're depressed, they're anxious. So you really have to be careful with diagnosing or labeling something as long COVID or post COVID associated syndrome. But basically the CDC has tables and categories for approach to evaluating a child for long COVID and or PSC. And long and the short of it is that treatment for these long COVID children or children who may have long COVID, again, after excluding all other possible diagnoses, is really symptomatic at this point. And CDC does have a tremendous amount of information, as I just showed you some of these tables on their website for post-COVID, post-COVID, long COVID symptoms. And of course, children who go home post-COVID, there are specific issues that one would like to address post-COVID, which I'll talk about in a second in terms of return to sports. But long and the short of it is that for children who are infected with SARS-CoV-2 who are either symptomatic or mildly symptomatic, because there's been assessment of data and it shows the incidence of myocarditis is actually relatively lower in children with acute COVID. A phone or telemedicine visit with a pediatrician at the very least is recommended at a minimum. It is really better to have these kids in your office after they're off isolation to evaluate them properly. But an actual evaluation of the child is recommended for any child who tests positive, asymptomatic or mildly symptomatic. And as Dr. Byers mentioned, children their cases have to be reported to the Department of Health, of course, as well. And all individuals should be instructed on proper quarantine and isolation. Basically, if you do have a phone or telemedicine visit, basically, you should include appropriate questions about chest pain, shortness of breath, out of proportion for upper respiratory tract infection, new onset palpitations, or syncope. And any child who reports these signs or symptoms needs to have an in-office visit that includes a complete physical exam and a consideration of EKG should be given prior to clearance for return to physical activity. And really, at that point, you're probably referring to a cardiologist. It's probably the good thing to do. For those with moderate symptoms of COVID, who have not had MIS-C, they should not exercise until they're cleared by a physician, and primary care evaluation, of course, is also recommended with regard to quarantine and isolation, review of definitions and what's required for the family. And for the primary care doc who's seeing this child who's had moderate disease at the very least, of course, so symptom screen for chest pain, shortness of breath, new onset palpitations, syncope. All of these things need to be evaluated for. If cardiac workup is negative, a gradual return to physical activity may be initiated after 10 days have passed from the date of positive test or after symptom resolution, off fever reducing medicine. If there are any positive signs of cardiac involvement, you have to refer these children to cardiology. They cannot be cleared to go back to sports until they see a cardiologist. And for MISC, this is actually really quite straightforward. Basically, no return to sports until 3 to 6 months and seen by cardiologists. Cardiology has to see these children on discharge. For children who have had SARS-CoV-2 infection, who you have already cleared after presumably evaluating all of these parameters I just mentioned, no further work is necessary. And I just want to remember, I keep using this picture because I really love it, but just remember how important vaccination is. I keep saying to Dr. Byers, let's bring Elvis back. Because of course, Elvis was really instrumental as a very famous Mississippian in the polio eradication campaign. And we know that vaccine works. This is actually from the London Financial Times, but I thought it was a really pretty graphic that actually shows the efficacy of vaccination against the Delta variant. And this is, of course, as Dr. Byers had shown this graphic earlier, but you can see here, of course, if you go to deaths, 87% of those who unfortunately have died from COVID are those who are not vaccinated, and with few exceptions. We do know this is important just to mention, because I think this is important for schools. There was a study in medRxiv that showed that people basically were serially sampled either early after vaccination or later did have actually, compared to unvaccinated, substantial reduction in viral culture, in symptomatology, of course, for SARS-CoV-2, and substantial reduction in viral cultures for those who were actually more recently vaccinated or vaccinated versus those who were not. Again, we know vaccination works because it protects our children. And this is actually important for those of you, I know we're almost out of time, but masks work, guys. I know you guys all on this call know this, but I still can't believe people are asking this question, or people, sometimes I think all of us have probably gotten crazy messages from people saying masks don't work. They do. And this is a nice graphic that you can share with folks who ask you. The Delta variant basically spreads, of course, very easily. There was a teacher who took her mask off for a few minutes to read to the children in her classroom, and she was infected with COVID. And 12 of 24 kids were actually infected for her just taking her mask off to read to them. So remember, of course, we need to encourage people to wear their masks, wear them correctly, get vaccinated, stay home if sick, and test as needed. And of course, a study done in Mississippi, which we did with the Department of Health, we showed very clearly that children can safely attend school if they actually are attending schools where mitigation measures are in place to protect them, including masks and distancing and hand sanitization. Basically, kids who attended school with those measures in place are less likely to get infected than they are to be infected at home by a family member. And the Children's Foundation of Mississippi has this beautiful graphic they put together that actually provides a lot of references and data and evidence, and talks about scientific studies behind masking. And if anybody wants evidence, just give people the link to the CDC website. I just plopped this on a slide to show you how much information there is on the website. This is the website basically for masking evidence. There's a jillion references. So please just remember, there is plenty of evidence. If anybody asks, just be ready to give it to them. And I know I've only left like 3 minutes for anybody's comment on what exactly we can do to really encourage our schools other than what I've said. So in the last maybe 1 or 2 minutes, I'll let Dr. Byers or Dr. Henderson bring up any questions or concerns or anything else they'd like to say.
That was fantastic. You got through all those slides, and that was amazing. And we definitely will share. Share that slide deck so that people can look at those graphs and use them when they're talking to their school boards, because I think the best thing we as pediatricians, family practice doctors can do is talk with your local school board, use that data, use the graphs, really use any connection you have to support the schools that are enforcing masks, and then to try and educate the ones that are not. If anybody has questions, go ahead and stick them in the chat box, but I have just 2 real quick comments. If you as a pediatric office or family practice office are not giving the COVID vaccine within your clinic, I would encourage you to do it. We've been doing it at my clinic since, I guess since early June, and we've given hundreds of doses, and we have lots of parents who will not go anywhere else. They want to get it in their office. And so please reach out to the health department, Dr. Edney. I know it's a lot of work. I know we're trying to get our patients in with flu shots and flu clinics right now too, which is very important, but we have got to get our kids vaccinated against COVID. I feel like if you're not giving it in your office, you're kind of communicating somehow that you are not that invested in it, or that you're not you just don't have as much confidence in it. So I would encourage y'all to talk to the health department about that. Second thing, Dr. Byers had mentioned when, and this is a big question we get, when will it be available down to the age of 5? He can talk about that, but also just remember, really, those kids are 100% going to want it in your office. So let's go ahead and get every pediatric office in the state, every family practice office in the state giving COVID vaccines so that when it is available down to the age of 5, you'll be able to do that in your office. We want our kids in our office as the medical home. We want them to use us for all their needs as opposed to going to CVS or Walgreens or an urgent care. So please consider getting on board as a vaccine provider. And then if Dr. Byers has any comments about that vaccine down to the age of 5, I would love to hear it. And if you have any questions, stick them in the chat box, please.
Thank you. Thanks, Dr. Anderson. No, I don't have a hard date on when they're going to drop that age eligibility down. They've got lots of things that they're reviewing right now, including somewhat under some pressure to get some guidance out about booster doses and how that will include Johnson & Johnson as well. And so I think they've got a lot of things that are going on right now, but we had received preliminary information that it would be mid-fall that we would get that clearance down to kids under 12. But beyond that, no additional information. But the sooner the better.
And as a reminder as well, you can co-administer, COVID vaccine with flu vaccine with any other vaccine. So if anyone comes in and wants their flu shot, it makes no difference when they have had other shots and vice versa with the COVID. So there is no wait time for any vaccines and the COVID vaccine.
I have to sign off, guys. I apologize. I did not estimate my time very well, so I will not interrupt you further. But please, if anybody has questions, please feel free to email me.
Thank you
Thank
so much,
you.
Dr. Hobbs.
Sorry. Thank you.
And if I don't see any additional questions, so thank you all for joining in, for logging on. We, just have had a huge amount of COVID in kids. And so I think it's important for people who take care of kids to know what the latest guidelines are. Watch for that Miss C. Contact us if you have any questions, the health department. And we will hopefully see everybody again soon. Thank y'all for joining.
Thank y'all.